Welcome.
You're ready.
Am I on?
Yes, doctor.
Welcome. Sorry I cannot see you, but I'm very glad you're here. Now, imagine we eliminate preventable thrombosis globally. And with that imagination, we so decided to create a PACO Foundation, promoting awareness of clotting outcomes. This is our second annual meeting, and I'm happy to know that COVID-19 has brought to us a much different perspective of the reality of thrombosis. Remembering the classic Virchow's triad, the endothelial problem of COVID-19 has brought to attention many more challenges in the thrombosis reality. And for that reason, this year's meeting is going to focus on that very heavily. The delivery of care has changed. Now it's my enormous privilege to have as the chairman of this meeting, Lord Professor Honorable Kekar from the University College of London, director of the Thrombosis Research Institute of London. He is joining us to co-chair and chair this meeting so that we have understanding of what's the global impact of the thrombosis in the face of COVID-19. Professor Kekar, I'm most thankful to have you here. Please join us and we'll follow your lead.
Well, thank you very much, Dr. Tafur, for your kind introduction. It's my very great pleasure and privilege to be joining this PACO Foundation second annual symposium, as we've heard, on the subject of challenges in thrombosis management during the COVID-19 pandemic. And I think we all as clinicians recognize that the global COVID pandemic has highlighted to many clinicians who previously might have neglected the problem of thrombosis, that thrombosis remains a very real and serious problem for our patients, none more so than those suffering from COVID-19, where a clear thrombosis phenotype has been identified and where there has been a rush to understand how we might use anticoagulant therapy effectively to improve clinical outcomes, exactly the purpose of PACO. And therefore it's timely that we have this second annual symposium, which focuses on the use of anticoagulation to improve clinical outcomes across the entire cardiovascular system. A very thoughtful program that we will share over the next 2.25 hours, looking at the question of anticoagulation and clinical outcomes for the heart, for the brain, for the vessels, and then turning, of course, to the critical question affecting all of us as clinicians, our patients, the societies and communities that we serve, health systems and governments throughout the world. And that is how we might responsibly vaccinate against COVID-19 to protect patients and to ensure that the devastating impact of this disease, as we have seen it throughout the world, can be mitigated. But let's for a moment put COVID-19 to one side and think about the remarkable era in which we live with regard to anticoagulation. The last 10 years have actually built upon 3 decades of intense research activity. That intense research activity allowed us to expand the armamentarium of anticoagulation from unfractionated heparin and vitamin K antagonists to the low molecular weight heparins. The low molecular weight heparins were transformational for clinical practice. Originally evaluated clinically in the prevention of deep vein thrombosis and pulmonary embolism, experimental work, experimental evaluation of mechanisms of action, of structure-function relationships, led to broader consideration about the use of routine anticoagulation to improve the management of patients with acute coronary syndromes, to extend prophylactic anticoagulation from surgical to acutely ill medical patients in hospital, and of course to consider the routine utilization of malignant disease, in particular for the management of cancer-associated thrombosis. But during that period of development of the low molecular weight heparins, we saw, of course, further innovation in anticoagulation and the development of the non-vitamin K oral anticoagulants, the direct factor Xa and factor 2A inhibitors. And we have seen a substantial transformation of the anticoagulant landscape in the last 10 years through the increasing utilization of these agents for the prevention of thromboembolism in high-risk surgical patients, and through the broad utilization of the 10A and 2A inhibitors for the prevention of stroke in patients with atrial fibrillation, their use routinely for the management, the treatment of established venous thromboembolic disease, more recently their evaluation against low molecular weight heparin for the treatment of cancer-associated thrombosis. And then in the last couple of years, the use of low-dose factor Xa inhibitor, rivaroxaban in combination with aspirin, in patients with stable arterial disease, coronary artery disease, and peripheral arterial disease, where there is a suggestion that the combination of low-dose anticoagulation with single-agent antiplatelet therapy by way of aspirin can improve clinical outcomes. So there has been a transformation, but there are residual challenges, and those residual challenges are, of course, more broadly in identifying and intervening in patients where intravascular thrombosis remains an important clinical problem, and then more acutely in COVID-19, understanding how the thrombosis phenotype in these patients can be properly addressed. And here in this exciting program that we're going to share in the next couple of hours, we are going to be at the forefront of developments in the anticoagulation, thrombosis, and cardiovascular fields, understanding how this disease, how intervention to prevent thrombosis, and more broadly, intervention to target cardiovascular risk to improve outcomes, can play an important role in improving the management of patients with COVID-19. So the COVID-19 challenge is a combination. It is a combination both of the drive to effective vaccination and the drive to improve clinical outcomes for those patients infected with the SARS-CoV-2 virus. And in that regard, attention to the cardiovascular system, not only in terms of addressing cardiovascular risk factors and comorbidities, but through the appropriate and responsible use of anticoagulant intervention, offers the potential for substantial improvements in the clinical outcome of patients with COVID-19. It's now my great pleasure to hand over to Dr. Biller and Dr. Walanga, who are going to take us through the cerebrovascular thrombosis session. Jose, Janine, over to you.
Dr. Biller, Dr. Walanga, please activate your sound.
Okay. Good morning, everyone. I'll start again. I want to welcome you to the session. Welcome my co-chair, Dr. Biller. We're starting the question and answer period now, and this is the session on brain and ischemia. So first, in the session, there were 3 speakers. So my co-chair was 1 speaker. I'll just make sure introductions. Dr. Biller from Loyola University Medical Center in Maywood, Illinois. Veronica Cohn-Greverson from the Retina Health Center in Fort Myers, Florida. And Louis E. Drobo from the Leeds Neurosciences, Leeds Teaching Hospitals in the UK. So what I thought we would do is, since Dr. Biller, you were a speaker, if I'll take the privilege, if you don't mind, of asking you some questions that were sent in already from some of the participants. And we'll have you address those questions, and then we'll move on to the next speakers. So one of the first questions that I have is, given the severity of respiratory illness among the denominator where neurovascular disease is described, which things are different in proportion for COVID relative to other critically ill patients? Dr. Biller, if you can address this.
Thank you very much, and thank you for the invitation. Stroke has been associated with COVID-19 in approximately 1 to 3% of hospitalized patients, and higher rates have been reported with the more severe cases of COVID-19, those with acute respiratory distress, multi-organ failure. And we know that most often the strokes are ischemic and include large and small vessel disease. Hemorrhagic strokes, parenchymatous brain bleeds have occurred, particularly with the use of anticoagulation, and less common cerebral venous sinus thrombosis. There are rare instances of situations that resemble reversible cerebral vasoconstriction syndrome, as well as posterior reversible encephalopathy syndrome, particularly those with systemic hypercoagulability, systemic inflammation. Many of these patients had evidence of hypertension and renal injury. Now, many patients who have been diagnosed with ischemic stroke associated with COVID, the result of the stroke subtype often is attributed to cryptogenic stroke. And I want to offer a caveat because the reality is that oftentimes, because these patients are critically ill, ancillary tests that are routinely performed, like, for example, echocardiography, transesophageal echocardiography, may not be done in these patients. And that may be an explanation why cryptogenic stroke has been reported to be higher than contemporary and historical controls. So I would say that a higher incidence of this cryptogenic stroke with that caveat, but otherwise a whole spectrum of ischemic hemorrhagic strokes, including non-aneurysmal subarachnoid hemorrhage, large artery and small artery occlusive disease.
Thank you, Dr. Biller. There's going to give you 2 more questions before we move to the next speaker. So next question is, can you comment on the practice regarding dual antiplatelet therapy after stroke and COVID?
The acute stroke care of patients with COVID-19 should follow the standard guidelines for the management with acute ischemic stroke, regardless of the SARS-CoV-2 infection. And obviously, all necessary precautions related to infection control should be strictly followed. Regarding the dual antiplatelet therapy, the current recommendations of dual antiplatelet therapy based on chance and point trials is for non-cardioembolic, small ischemic strokes defined as those with an NIHSS less than 3. And therefore, under those circumstances alone, we will recommend dual antiplatelet therapy and for no longer than 21 days.
Is there any time you would look for extended prophylaxis in patients?
Extended prophylaxis from the viewpoint, the hypercoagulable state remains, and usually the recommendations have been for a month and a half. But if you are asking about, this is in reference to anticoagulation, as far as the dual antiplatelet therapy, independent of COVID, some people recommend up to 90 days, but then the risk of bleeding associated with dual antiplatelets exceeds the benefits.
Good. And then the follow-up to that is, how do you measure bleeding risk?
Well, generally speaking, in patients who have arterial ischemic stroke, arterial, non-cardiac, we do not use anticoagulation except for thromboprophylaxis or prophylaxis of venous thromboembolism.
Okay, thank you.
So we will use either monotherapy, antiplatelet monotherapy, or dual antiplatelets according to the parameters previously discussed.
Okay, and one final question. Is there an increase in dysautonomia, if I'm saying that correctly, loss of balance that after COVID? I'd like to go to that also, this brain that people talk about after COVID. That they can speak to these, and if there's any potential pathophysiology that we might know.
Sure. In regards to the dysautonomia that we usually define as impairment, and by that we mean either failure or overactivity in the function of the autonomic nervous system, they are isolated case reports of autonomic dysfunction that may account for the hemodynamic instability of these patients. Regarding the sequelae, I think that this is going to be a major challenge in addition to the neuropsychiatric sequelae. Certainly, I think that many behavioral changes and what has been now known as the COVID brain equivalent to the chemo brain is something that we may have to be dealing with, among other post-COVID complications.
Good, thank you.
Thank you very much.
Yeah, thank you so much. So I'm going to move to the next speaker, which is Dr. Cohn-Gregersen. So I have questions for you here. And we'll also ask the participants that you can go and add questions if you need. So Dr. Cohn-Gregersen, first question, for which is Dr. Cohn-Gregersen to remind you, gave an interesting talk. I enjoyed listening to it on thrombosis in the eye. So related to that, for which ocular findings do you think thrombophilia evaluation is warranted?
Well, thank you. First, thank you for inviting me. It's a broad topic, but let's try to summarize it. So if it, depending on the age of the patient, if it's a young patient that comes to me with a central retinal vein occlusion, for example, I will need to evaluate for any family history of thrombophilias, and certainly I will send them to the primary care physician to evaluate for that, for the most common factors that can be inherited, especially like protein C, protein S deficiencies, or factor V latent. So those are the primary things that we need to rule out. If it's a patient that is young but has an arterial occlusion, well, we will need to think about something autoimmune, and then we will run the panel for that. If it's an older patient but with atypical characteristics, for example, not long ago, like 2 weeks ago, I had a patient with a very asymmetric diabetic disease. And in that patient, I sent him for a carotid ultrasound, because when you have such an asymmetry in a disease that is predominantly bilateral and pretty much symmetric, you need to suspect that there should be some component of ischemia. And in this case, the patient was confirmed to have a total occlusion of the carotid artery on that side. So depending on the age and on the whole family history, we need to team up with the primary care physicians primarily to do tests and to try to find out what is the culprit.
Great, thanks. Next question. When in the COVID trajectory are the ocular findings most prevalent?
Unfortunately, I think that at the beginning, nothing has been completely addressed regarding the ophthalmic manifestations. There was a lot of fear. I don't think that this has been truly investigated, because patients, most of the severe cases, that is when I would expect to have ophthalmic manifestations, the patients are in the ICU, are intubated, they cannot talk and explain or describe these ocular symptoms. But has been described that they can be microangiopathies. There is, I think, one case report of an arterial occlusion. But if you ask me what is my thought, my 2 cents would be that between the 7 and 14-day range is when I would expect most of the pathology. Of course, patients will need to be evaluated at that time, most likely while they are in the IC unit.
Excellent, thank you. Okay, and next question. Are there other viral illnesses with ocular ischemic manifestations, and if so, suggested management?
Well, the first or the top 3 that would come to my mind, well, the COVID that we have spoken about, and then it would be the herpetic diseases. Herpes, it's prevalent in a lot of people. They remain dormant in our body, and it can affect immunocompromised as well as immunocompetent patients, and they cause a severe necrotic retina that it's very prone to have, like, up to 86% of them can have retinal detachments, for example. So it's a very, the morbidity for the eye, it's extreme in those cases that presents with acute retinal necrosis. West Nile virus can cause vasculitis, occlusive vasculitis. And another thing that I've seen is in patients with hepatitis C, particularly hepatitis virus. I have seen a couple of cases with cryoglobulinemia. And in this particular set of patients develop cryoglobulinemia, and as a side of that, can present retina manifestations of occlusion.
Very interesting. Thank you so much. Thank you. We're going to move on. Thank you. We might come back to you. We're going to move on to Dr. Idrovo. Good morning. So questions.
Hello. Thank you very much.
You're most welcome. So your topic was on antiphospholipid syndrome and the brain.
Correct.
So first question for you. Given the prevalence of post-COVID antiphospholipid syndrome, is there a value of aspirin for primary prevention in selected groups?
Well, that's an interesting question, and I don't think that has been evaluated before or currently. But some patients that present to our hospital with sometimes other conditions, non-neurological, and they're screened for COVID, because every patient that is submitted to our hospital is screened for COVID. We don't tend to put them on any antiplatelet therapy. I'm not aware. I don't know, Prof. Biller, if you're aware of any studies or any recent data about that. But we don't tend to in our protocol. We don't start them on any antiplatelet therapy at this stage.
Okay, thank you. Thank you. And then next question, in practice, what do you estimate when to re-anticoagulate an antiphospholipid syndrome patient who had an intracerebral hemorrhage? Dr. Biller, maybe.
Well, yeah, that's a difficult one, and actually I've been reviewing the topic more recently, and that's the case. I presented a difficult case with recurrent hemorrhage and thrombotic events. There are not clear guidelines about when to restart. This controversial information out there in the literature. However, we could classify patients in two broad groups: the ones that we have a high risk of thrombotic events, and the ones that have a lower risk. In the presentation that on the case that I presented, I highlighted that our patient was a triple positive antiphospholipid, had previous venous thrombosis, previous DVT, pulmonary embolism, cerebral venous thrombosis. So when she had the bleed, we thought that after doing follow-up scans, 2 weeks was the ideal time. Unfortunately, that patient had a thrombotic event while she was waiting for the anticoagulation, to be restarted. So I think if a patient is a triple positive antiphospholipid with previous thrombosis, I think we would consider that a high risk patient. And in that case, possibly 2 weeks could be the time frame that we would use, depending, of course, of if there's no hematoma expansion and there's no other contraindications to an early restart.
Of course, yeah. Dr. Biller, would you like to make a comment?
Many of the reported cases of stroke with COVID and antiphospholipid antibodies, lupus anticoagulant, cardiolipin, IgG, IgM, or beta-2 glycoprotein, IgG, IgM antibodies. Unfortunately, in most of the studies, they didn't have repeated studies, so it was a single observation, and therefore one has to be very cautious in adjudicating antiphospholipid syndrome as a cause of the stroke. It could be, and we know the viral hypercoagulability, on the other hand, can be an acute phase reactant. Whenever we discuss the whole issue of restarting anticoagulation in patients with high thrombotic risk who had an intracerebral hematoma, it's a very difficult decision. And by and large, we try to stratify the patient. What is the greater risk? Is it a greater risk of thrombosis versus bleeding? Sometimes we use the Has-Bled score for the risk of bleeding. That is not perfect. And obviously, we need to determine what is the underlying source of the bleeding. If the underlying cause of the bleeding is supratherapeutic anticoagulation, then that shouldn't be an issue. If it's uncontrolled hypertension, we have the answer. But if on the other hand, the patient has, let's say, cerebral amyloid angiopathy, then the risk of recurrent bleeding is much higher. So in answer to your question, we don't know the full answer. I think 10 to 14 days is an accepted delay, but every case should be individualized.
Yeah.
Thank you. So Dr. Idrovo, I have one more question for you.
Thank you.
Do you add hydroxychloroquine into antiphospholipid patients with a history of anticoagulation failure?
Sorry, I missed the first part. Can you say that again, please? Sorry.
Do you add hydroxychloroquine to antiphospholipid patients with a history of anticoagulation failure?
Oh, that's a good one. That's right. Well, now it's possibly more trendy with the COVID, but well, I think the evidence and the only one of the occasions that we could consider hydroxychloroquine would be in patients with lupus, for example, because that medication has anti-inflammatory and immunomodulatory effects. But normally, when the patient has also obstetric antiphospholipid, when we see those patients referred to our clinics, they already come with that medication. They already been prescribed. So yeah, that's a medication to be considered. Correct.
Okay, interesting. Okay. Dr. Biller, do you have any questions for the other speakers? We can't hear you.
I greatly enjoy the presentations. I think that clearly there is a unifying theme, and there are many questions that remain unanswered, and only through serious research, not just isolated case reports, that oftentimes the association doesn't necessarily mean causality. So I think that we have to still be a little bit cautious. But thank you very much.
So I do have a question from the participants in my chat box, and actually it's Dr. Biller. So the question is, when compared to neurovascular manifestations in post-vaccine pandemic era? What neurovascular manifestations do you anticipate in post-COVID-19 pandemic era?
What we anticipate in the post-COVID-19 is a variety of central nervous system and peripheral nervous system manifestations, such as some will be non-fully defined, but chronic fatigue, behavioral changes, the brain fog, myalgias, we have to understand that some of these patients will have the sequelae of critical illness polyneuropathy or myopathy. They may be weak. They may have had Guillain-Barré that has been reported in many of these patients, and that may be protracted. The types of GBS that have been demonstrated were either demyelinated or axonal. But as far as specifically cerebrovascular, it will be the sequelae of the stroke that will not be different from the sequelae of other patients without COVID with stroke. But certainly there will be a whole gamut of neuro-COVID, behavioral COVID that we have to deal with.
Yes, right. I guess the same question to Dr. Cohn and Dr. Novo too, if you have any comment on this question about how the post-COVID era can compare to the post-Spanish flu era with sequelae of patients with their symptoms. Any thoughts?
Just a quick comment. It is interesting here in the UK, there's a condition that we commonly see in the outpatient setting, and it's referred as ME. So it's like a post-viral encephalitis, kind of fibromyalgia, chronic fatigue. And I have to be honest, it's a condition when I came to the UK from Spain, we tend to see quite often. And I was quite concerned. I said, well, is this psychological? Is there any psychiatric manifestation? Because they have, migraine, chronic fatigue syndrome, the triad. But then now I'm more aware, and I'm kind of understanding, because we see patients post-COVID with the same symptoms: fatigue, lethargic, confused. So it's quite interesting to me.
Yeah, if I may.
In patients with viral diseases, any viral disease, not necessarily COVID, we tend to see, particularly in women, or if they're nearsighted, if they're myopic, they have a high tendency to have some inflammatory conditions in the eye too. With COVID though, I would say that we have had the tendency to see a little bit more of the thrombotic events, vein occlusions, for example, that it could be just a coincidence. A couple of patients have had a history of recent COVID, that it wasn't severe, but of course these patients are also in the age group that are at risk factor. It's a risk factor for having a vein occlusion anyway. So it's too early to say, as Dr. Wheeler said. We need to do research to find out what is the end game of all this. But at this point, we just need to keep our mind and our ideas open to see what can we investigate and do in order to protect the patients or try to prevent further complications.
Thank you. Dr. Wheeler, you had a comment?
Yeah.
Can't hear you.
Stations of COVID-19 is hyposmia or anosmia, hypogeusia, dysgeusia. That tends to resolve, so will be unlikely that it will persist, but it's too early to make a definitive statement. But I agree with Dr. Hidrovo, this chronic fatigue, fibromyalgia, that has been, as pointed out by Veronica, not uncommonly seen with a number of viral diseases, Epstein-Barr virus, etc., of chronic fatigue. And certainly many of these patients are unable to return to work. So I think that this is going to be very, very challenging.
Well, thank you. I have one more question from the chat box from the audience for Dr. Cohn. If someone is found to have a thrombophilia with the eye disease, how would you treat them differently? Anticoagulation, perhaps?
Yeah, if the patient has a history or family history, we will need to send him to the general physician to determine what anticoagulation will be best depending on their whole general state of health. Yeah. And in the eye, well, depending on the manifestations, nowadays, one of the medications that we use most commonly is antivascular endothelial growth factor. And one of the things that we always are cautious are specifically with patients that have a history of heart attack or stroke, because one of the most common agents that we use that is off-label is Avastin. And the studies haven't shown a definite increased risk, but they think that patients that have had history of a stroke or a myocardial infarction may have a slightly higher risk of having a repeated event. Clinically, I have not seen that, and we use Avastin every day in our clinics, but the data doesn't lie, so we just need to be cautious in those patients.
Thank you. Dr. Biller, any comments, any questions for our panel here? Our time is almost up for the session. Can't hear you. You're muted.
Further comments. Thank you very much. It was excellent. I learned a lot, and I appreciate your invitation.
Yes. So I will thank all of our panelists, including you, Dr. Biller. Thank you for your presentation. Thank you for the question and answer session. Very interesting, as Dr. Biller said. I learned a lot from everybody, and there's more to learn, it seems. So we've got a road ahead of us. So to be interesting times. So I think I'll turn it back now to Professor H.A. Kaker. And thank you.
Dr. Walanga, thank you very much indeed, and Dr. Biller for that very interesting session on the brain and ischemia. We're now going to move to our next panelist session, where we'll take questions that have been received during the period after the uploading of the presentations. And of course, you can continue to submit questions using the chat function. And I'm going to call upon Dr. Irwin from North Shore University Health System and Dr. Tafour, our president, to moderate this session on the heart, thrombosis, and anticoagulation.
Thank you very much, Professor Kaker. We're going to have this session, as you indicated, Dr. Irwin is joining us. Thank you very much. And Dr. Kamar, I think he's going to be a voice only for some difficulties. I remember not so many months ago, Dr. John Irwin joined North Shore, and he joined North Shore in the middle of a catastrophic change around the world. And then he was summoned to manage the Department of Medicine or institution with COVID increasing. Now, of course, that actually has generated a lot of changes on delivery of care. So in hindsight, starting that in that perspective, given that your lecture was precisely on that orientation, which were the biggest learning points that we can probably transmit to other institutions who are still on the upwave as to understand the logistics that were the best return on investment when they were changed?
Great to be here. Thank you for having me today. It's been a very interesting time to move across the country into a new environment. And so I think I had a very steep learning curve. We tend to take a lot of things for granted in medicine. You know, we generally think that we show up to our work and things are there for us to use, our tools are in place, and I think somebody needs to mute. But in terms of the things that we learned is that our supply chain and the way that our teams work together are paramount. And, you know, I think we saw the best in people through this. It's been an amazing time to see people step up, We even had doctors that had not practiced in a hospital for many years come out of the clinics and actually get trained up on how to be assistants with us in the hospital setting. And so I think that the key takeaways are, one, having a well-oiled team with the types of work that are going to be done to be well-defined. And then two, ensuring that we've got our supply chain, that we've got the things there that we need to protect ourselves, to protect our patients, and to make sure that we can give the best care possible.
Understood, indeed, and especially those are within the institution. I'm understanding these are steps that we're trying to learn into as a potential second wave will appear. We're going to do this intermittently, of course, and then if you want to take a question for Dr. Kumar anytime soon. In the meanwhile, let me actually notch Dr. Baumann. Dr. Baumann joins us from Medical College of Wisconsin. She is one of the most esteemed colleagues I had in my cohort at Mayo Clinic, and she's the founder of co-founder of Venous Thromboembolism Network in the United States, and panelist on multiple national guidelines, including the NIH guidelines for COVID management. So, Lisa, whenever I have a question on ECMO, I reach out to you. So, have you seen more? Given the high fibrin content in the patients with COVID, have you seen the need of more frequent circuit changes? And how are you managing your usual patient that ends up having ECMO associated with COVID?
Yeah, thank you. Thank you so much for inviting me to be a part of this. And I have to admit, we definitely have seen ECMO thrombosis. Whether or not it has caused more circuit changes in comparison to other severe inflammatory disorders is still yet to be determined, I think. There is not a great comparison. Definitely, we would anticipate a patient with COVID to be different than other non-inflammatory diseases that require ECMO. And so from that perspective, we need to be cautious of what our comparator groups are. But yes, we most of the time will see a very high fibrinogen level in our patients with COVID-19, especially our critically ill patients that require ECMO. Our management approach to things have changed over time, and they definitely change as the patient condition does as well. When the first part of the pandemic hit, we were seeing more of the thrombotic complications, and we did kind of move our anticoagulant strategy, intensify it, I should say, from a heparin perspective. More recently, we have been seeing more of the bleeding complications associated with patients on ECMO, so more mucocutaneous bleeding. And so we have kind of swung the pendulum back in the other direction and are back to our lower rates of heparin for those patients. But it does need to be individualized, of course, and the patients may be more prone to bleeding or clotting depending on their situation as well. So unfortunately, we don't have a complete answer for that yet.
Sure, thank you, Lisa. Dr. Irwin, is there a commentary that you want to aside or something specifically to ECMO for Dr. Baumann, perhaps?
I'm sorry, you broke up a little bit on my end. Could you repeat the question?
Absolutely. So I was wondering if there's a follow-up question that you've seen that assistant issues that we can have Dr. Baumann look out into for the ECMO patients.
Yes, in terms of the number of patients that we had on ECMO with COVID-19, most of them didn't end well, although we did have a learning curve that went along, and we saw that as time went along, and especially with your great assistance in management of the anticoagulant, we saw the outcomes significantly improve as time went on. From talking to people across the country and globally for that matter, I think the same thing was seen across the spectrum of the months as we learn more.
To that end, Lisa, I follow-up questions on that topic. Early on the disease severity, the sicker that you get, the antithrombin levels will decrease in these patients with COVID. And then there's a nice association between the level of sickness and low antithrombin. Which are your thoughts on the advantages and disadvantages, both drug-wise and logistically, for utilizing a DTI, aka argatroban, as a first choice?
Yeah, this is a great question, and we definitely discuss it frequently in our units around patients as well. So I think in this does depend a little bit on what your laboratory is also using for monitoring. So at our institution, anti-10A monitoring is standard, and our anti-10A assay does not have antithrombin added to it. And so what our measurement of heparin activity is truly the patient's antithrombin and what the activity of that heparin should be in the patient themselves. So that's going to be different if you are at an institution that adds exogenous antithrombin to your anti-10A assay, or if you don't have access to an anti-10A assay and all you have is APTT. So know your laboratory and know what you have for availability. So when we do start to see our need for heparin increasing, so we're starting to see that patients are needing 25 units per kilo or higher of heparin, we will look for antithrombin and see if there is a deficiency and that's the reason for it. And then consider either supplementation of the antithrombin or just switching them to a direct thrombin inhibitor at that point in time. There is definitely a cost issue. The direct thrombin inhibitors are much more expensive. And in many institutions, including my own, they are run individually. There's not a nurse-driven protocol like there are for heparins. And so it does provide a different set of management strategies and need for differences in attention instead of a kind of automated protocol like we do with heparin. So those are the things that we take into consideration. And we definitely have needed to use direct thrombin inhibitors for our patients on ECMO with COVID-19 because of that.
Thank you very much, Lisa. Indeed, remains a challenge to play with more than one option. Let me invite Dr. Kamar to take a question as well. As you may recall, Dr. Kamar gave us a lecture, which is on the website, on management of intracardiac thrombosis, going from ECMO to actual intracardiac thrombi. Dr. Kamar joins us as an interventional cardiologist and a vascular medicine specialist. He's recently started in North University Health System, coming up with graduate with honors in Harvard Medical School. He also holds an MPH with heavy clinical interest on early atherosclerosis and thrombosis management. Arman, welcome. Could you illustrate me a little bit on how your thought process is when you see a cardiac thrombus? Is it really value either opinion or data as to consider this thrombus not all the same, meaning device associated with the right ventricle versus left ventricle? How do you approach this mentally when you organize yourself for approach?
No, thank you, Dr. Tafur, and very excited to join the group, and been learning a lot from all the presentation that has been uploaded. And so like you mentioned, that intracardiac thrombus is a very interesting topic, and unfortunately, I would also say an area in thrombosis that has been ignored, again thought to be a zebra, but really not a zebra actually. We do see it quite often, and especially now with our patients who are surviving longer with advances in cancer therapy and other forms of cardiac disease. So to answer your question about what is my approach, so when I get called in to help or assist with the management of a patient with intracardiac thrombus, I divide my approach in terms of management into a three part. The first is that what is the cause? The second is that how do I manage it? And third, how do I follow it and prevent it from happening. Now, in terms of the cause, as the group must have seen it on the presentation, a lot depends upon where the location is. So most commonly, intracardiac thrombus are seen predominantly in the left ventricle. The cause in the past used to be generally, late presentation, anterior wall MI, and then they formed a thrombus probably because they got their PCI way after the infarct had completed. So that's one setting. But some of the centers have reported that commonly that is decreasing, which seems that we can give a pat on our back. That seems like we're doing a good job in opening these occluded arteries right on time. So patients with dilated cardiomyopathy, they could also form thrombus. Now, in other areas, patients with atrial fibrillation, you will see a thrombus in the left atrial appendage. And in the setting of COVID, I was in New York before moving to Evanston. So again, we had seen a lot of patients with COVID-19. And interestingly, we are seeing patients with COVID-19 presenting with not having MI, but having thrombus both in the right ventricle and the left ventricle. So commonly, patients with more of a systemic hypercoagulable state, you could expect thrombus in the right ventricle or in other chambers, patients with cancer or antiphospholipid syndrome. Now, in terms of the management of these patients, the most important thing to ask is, will this patient tolerate anticoagulation therapy? Now, most are, unless we see them late, and by that time this thrombus has gone to their brain and they have a stroke with hemorrhagic conversion. So most of the patients are a candidate for anticoagulation therapy. Now, in terms of what form of anticoagulation to use, unfortunately, we do not have any randomized trial to answer what therapy is better compared to another. In the past, because as you know, our colleagues, our friends in Europe, they probably do a better job than what we are doing in North America. The ESC guidelines are more updated. The guidelines that we have in North America, a little late. So most guidelines, though, would say that warfarin should be the preferred agent. But again, based on expert consensus, no clear randomized trials. I personally, given, for example, under your mentorship in our vascular medicine program, we get a lot of referrals and we see a lot of patients who we feel very comfortable managing with a direct oral anticoagulant. So I feel very comfortable managing most patients with intracardiac thrombus with a direct oral anticoagulant. The patients with devices, in that case, generally prefer warfarin. I do involve patients regarding what the risk and benefit is, and I tell them that, we are in a data-free zone, and I let them work closely with me when I'm making decision about what agent to use. Most patients certainly need anticoagulation for a period of at least 3 months, and I follow them very closely. Now, again, I think our patients, of all of our patients in our practice, if they have formed a LV thrombus, it's a systemic disease. It's not that the thrombus has gone away and now they are fine. Not really. These patients are at a high risk for recurrence, high risk for stroke or systemic emboli. So I follow them very closely with serial imaging, and then I also follow them closely about what their risk of bleeding is.
That's an interesting point. I mean, I love what you say that it's a systemic illness. We often forget to see the rest of the person when we're focusing too much on the heart. Thanks for that perspective. Indeed, there's a lot to consider in the same patient. I really enjoyed your lecture, by the way.
Thank you.
Irwin, I have a question from audience, which I really, it wasn't assigned, but I think it's definitely for you. Some of you may know Dr. Irwin has a follower list of, I don't know, over 20,000 people on Twitter. And the question is, with all of the misinformation happening around the COVID topic, which is the right voice to acquire, which is the responsibility from the medical field actually to make sure that we curate all of this information. So what's your opinion on that?
Yeah, it's a wonderful question. I think we all know that we have a direct responsibility, that patient that we're with at the bedside at any given moment. But I think also people turn to every physician as being a leader, whether you have a leadership title behind your name or not. Physicians, nurses, healthcare respected officials, other clinicians are considered to be leaders, and especially by those that are in the lay public. One of the things that I've really enjoyed about social media is the ability to kind of debunk myth and also to be honest from the standpoint of pointing out what we do know, what we don't know. I think one of the biggest issues with this pandemic has been obviously when a public health situation arises, that is a new situation. This is a novel, new disease that we're dealing with. And obviously, everyone on this call knows this, everyone on this seminar knows this, but our knowledge evolves. And unfortunately, that can be confusing to our public, to those that don't understand that science isn't the truth, it's the search for the truth. And as we continue to search in earnest, we discover new things. And so the commentary may shift. And I think it's important that we help to get that out there to the public. And I think it's important for healthcare professionals, clinicians, to be on the forefront to help combat that false narrative that tends to develop organically in the absence of good information.
Thank you. That's indeed a responsibility for us all. And you quoted that I read written in the walls when on the Mayo days, which you were there a couple of years before us. Knowledge is to know what you don't know, and that remains very true to my heart. A follow-up question to you on a similar topic. There's been some delays on care because patients, because of misinformation or something else, have had fear to access. I remember actually quite a few young MI patients that arrived late, and really there's an opportunity lost. So two questions in there. So one on the aspect of how to reach to them, and in the other aspect, how do we actually bring back those people to the system when we now have a waiting log of individuals that didn't get care in time?
Absolutely, and it's a complex situation, but I think to simplify things, we have to do it in every way possible. I think utilizing some of the power that our electronic health record does have. I know that many times our EHRs tend to be those things that we feel enslaved to and tethered to some degree. But there's also an ability for us to look at our patient panels and to be able to send out widespread messages through our electronic health portals. And I think it's important that we be proactive to reach out to our patients and tell them that it is safe to come back into the medical environment and to get the care that they need. And I think also to echo what we're seeing in terms of public health numbers, that our death rates have significantly increased. They're 25% to 30% higher across our country over this period of the last 6 months than what we would have normally expected. Now, some of that probably is due to COVID. Other is people. We saw the number of heart attacks go down in our hospitals. People were still having them, and they were having them at home, and so some of those people were dying. And I think we're still yet to see some of the very sick people that have allowed the sort of natural disease process to occur, and that we're going to pick up at a later stage. I think it's also incumbent upon us to try to get out to our press, both our hospital patient relations, the media relations, people that can go out and help us to amplify that, as well as getting out to our own, the mainstream media to talk to our patients. People want to know, but again, you're right. They're very concerned. They're very afraid, and I think that it's important that we use every portal available to us, whether that be social media, whether that be electronic health record, whether that be lay press. We need to be out there and discussing with our patients to make sure that we can keep their health first and foremost.
Thank you. What I hear and resonates with me is that in both the latest questions, you're empowering physicians, because at the end it's our responsibility to make it happen. It's nobody else's. On that same note, Lisa, some of the patients that we've seen with COVID have difficulties with a lot of sequela, and of course, patient who has been on ECMO, has been in ICU, they're heavily debilitated. So do you have a post-ECMO or post-survival of ICU COVID program what's the team development that you actually consider so that we bring back that person that's surviving, but that doesn't mean that they're fully integrated?
Yeah, that's a great question, and we are kind of it hasn't been done in a organized fashion until recently at my institution, and kind of in many institutions as well have looked at this as far as having a post-COVID clinic. where people can come and be seen by cardiology and pulmonary and hematology and psychiatry and all of the potential multidisciplinary team that is going to be required to care for these patients. And so I think it's an opportunity to align patient care as well as potential research opportunities as well, because you have your cohort of patients that then are recovering from critical illness, in which to help understand these long-term complications that we're starting to really hear about.
Indeed, a lot of research opportunities as these people recover. Armand, because I know some of your research interests, a lot of this disease is endothelial dysfunction. I mean, finally, we vascular medicine physicians, we got a disease of our own. So what would you propose, or what would you integrate for endothelial evaluation of the progress of these patients as they recover with the disease? Have you encountered something that probably becomes useful for us to see and monitor them?
Well, no, absolutely. I think that's a terrific and a very important question. And Dr. Tafur, do you mean that in the setting of COVID-19?
Precisely in the setting of COVID and endothelial illness.
No, absolutely. Yes. I mean, I personally have been amazed at, again, so when we talk about the endothelium, we are talking about both on the venous side, but importantly on the arterial side. And I've been amazed with many patients who are coming to our clinic because they recently were admitted with COVID-19. And no real risk factors for atherothrombosis or arterial thrombotic events, but developing stroke and MIs and also atherothrombotic limb complications. And the question is, there must be something unique about these patients. Now, some of that predisposition could be genetic, and I know with the registries, across registries of COVID-19, there is some interest, or there are studies being planned or being performed looking at genetic susceptibility for vascular events, whether it could be in the brain or in the MI or in the arterial bed. So that's the genetic component, but the other component is that our patients who have endothelial dysfunction at baseline, are they more predisposed to develop thrombotic complications from COVID-19? That's one area that would be worth exploring. Unfortunately, that kind of study would be hard to do because we'll have to study a lot of healthy volunteers and see if in future they develop COVID-19. But one area
that's the problem on the application of it. Thank you, Armand. I'm looking forward actually to do that precisely with both you and Lisa in the foreseeable future. Dr. Irwin, I would please ask you to have some final thoughts closing on this session as we move to the next segment.
I really appreciate this conference in the sense that it's bringing together a very ecumenical team of people with very varied talents and skills. And that's what it's going to take for all of us to get through this and to come out of it with the knowledge it's going to help us get the best care possible to the patient. I've been tremendously proud of our medical culture across the world and how we've responded to this. People have run into a fire with gasoline cans under their arms trying to save people, and it's been a very proud moment. I think we're all very tired right now, but I'd ask everybody to keep up the good fight because we are doing well, and it's going to be a little longer haul for us to sort this out. But I really appreciate all the keen minds that are involved here today, and I look forward to learning more from you as we go further.
Thank you very much. The wish is mutual, and thank you for your leadership during all of these moments. Thank you both for the panelists as well. I'm moving on to introduce Professor Pierluigi Antignani. We're honored to have Pierluigi Antignani is the president of the International Union of Angiology. He joins us right now from Italy. He's the director of the Vascular Center Nova Villa in Rome. He is the honorary president of the Italian Society of Vascular Investigation. And I've requested Professor Antignani, if you may, we had a poster presentation that happened in the last week, and it would be very appropriate if we present an award to our esteemed presenter. So please join us, and thank you very much for being here.
I thank you very much for invitation, and it's an honor for me and a pleasure to stay here in this very interesting congress, very interesting symposium on this very dangerous pandemic of COVID-19. And I think now there is the hour for about the poster.
Yes, I'll put the poster in a second, if you can present it, of course.
Yes.
So I have a written copy with me as I try to read. This is the first Caprini Awards recognition for specifically junior poster presentation presented to Rashi Babanad. His title of presentation was "The Risk for Deep Vein Thrombosis in Patients with COVID-19." So this document will, of course, be sent to him. Then, Professor Kinani, if you can mention the words why we ended up naming these the Caprini Awards as we find the screen share.
Okay. So it is a pleasure to give the award, the Caprini Award, to the Dr. Ravi Drudasila. The name of the doctor is, I don't have the list.
So it's the Dr. Rashi Babanad. So okay. I apologize for the interruption. My share screen button was turned off apparently. I will invite. Oh, there you go. That was missing here.
Okay.
There you go.
Right. No, okay.
I think you should be able to see it now, correct?
Yes. So the first Caprini Award of recognition for the junior poster presentation. Rashi Bapanad for the poster entitled "The Risk for Deep Vein Thrombosis in Patients with COVID-19." It's a very important topic. So it is a pleasure to give the Caprini Award out to this doctor. Compliments and congratulations.
Thank you very much, Professor. And as a reminder, the Professor Caprini, he's going to join us in the later lecture. He's the founder and creator of the Caprini Risk Score, which has been validated in over 3 million individuals around the world as one way more to prevent thromboembolism when we have adequate risk stratification. We named this award actually for a young poster presentation because we had given the Global Thrombosis Forum Partnership multiple very young individuals, high school level, presenting very high level topics, which will be shared in the selected topics will be shared in the website. I would like to invite Professor Kekar and Dr. Farid as well to the screen so that we can consider the awardee for the second topic before we move to intermission.
Well, thank you, Dr.
My great pleasure to welcome.
Go ahead. Yes.
No, go ahead. I was just going to, not that he needs any introduction, but I was going to introduce Dr. Farid, who of course is a giant in the field of thrombosis and anticoagulation.
Please go ahead, Professor Kekar.
No, I'm just saying what a great pleasure it is to be joining you in this session for the abstract competition #2 PACO award, and to say a few words about your remarkable leadership over the last, it must be 45, 50 years in the thrombosis field, with remarkable contributions that have resulted in so much of the knowledge and understanding we have in terms of modern anticoagulation and thrombosis management. Professor Farid, over to you.
Thank you very much. It's also a great honor for me to be in this meeting. And Professor Kekar, thank you very much for your kind words. As Dr. Irwin mentioned, we are in a very interesting time, and we are all learning and getting advanced knowledge regarding the pathophysiology of thrombosis, which is so complicated, and in time we will develop our momentum both medically and device-wise to treat these patients. The Caprini Award, which was presented by Professor Antagnani, was conceived and planned to recognize Professor Joseph Caprini for his lifetime achievement and his dedication in mentorship of younger people in particular, which he has done for almost 50 years. So we are very grateful for Dr. Caprini, and hopefully we are going to continue to have his leadership in this area and learn more from him. The other award, which is for young investigators, fellows, residents, and brilliant scientists in thrombosis and hemostasis, is the annual PACO Award. And this year's award is given to Dr. Diaz-Quintero on his work on the outcome in patients receiving dual antiplatelet therapy in combination with direct oral anticoagulants, a meta-analysis. So if we can show that award, I can read that, please.
Absolutely, Professor. So I'm putting the screen share here. Okay. Should be in your screen.
So the PACO Foundation Award of recognition for the best poster is presented to Diaz-Quintero for the poster entitled Outcome in Patients Receiving Dual Antiplatelet Therapy in Combination with Direct Anticoagulants. The organizing committee, which was chaired by Professor Antagnani and some other external reviewers, decided to give this presentation to Dr. Diaz for not only his poster, but his elegant presentation, which he made last week. So we are very happy to have these two awards on behalf of the International Union of Angiology, PACO Foundation, and Loyola University Medical Center. Since I have the podium, just for one more minute, I want to thank my most sincere thanks and gratitude to Professor Ajay Kekar. Lord Kekar is very busy with parliamentary activities in these days in Britain, but he, like his father, who has pioneered thrombosis and heparin and low molecular weight heparin, which were discussed to be transforming the platform of standard of care, were conceived and developed by him. Under him, we also did some work. So thank you very much for sharing this meeting, Professor Kekar. Professor Antagnani, your leadership to the IUA is exemplary, and we are very happy that you took the time to participate in this meeting and endorse our activities. Thank you, Dr. Tafur, for this opportunity, and congratulations to these two awardees.
Thank you very much, Professor. And I will name also that Dr. Raina, a student, Dr. Raina Shinghal, was a co-author of the winner poster for the Young awardee and the Caprini Award as well. For minor housekeeping issues, we have an intermission of those to 9 minutes, and we'll start sharp at 11:25 for our last two sessions. Thank you very much for attendees.
Thank you. How are you, Professor? Professor Antagnani, how are you?
How are you? I'm fine. You?
Very well. How is the weather in Rome?
Today raining.
Yeah,
Today is
it's
raining.
winter has started in the United States. So we are now in the 40s temperature-wise.
No, the climate is good, only rain, but the temperature is good. The famous October summer.
first call will be starting again in the next 3 minutes. Thank you very much. We're starting in 1 minute. Thank you very much for rejoining. Welcome back. Thank you very much for joining us again. For the next section, we will have the vessels in thrombosis given COVID, and then our keynote speaker updating us on vaccines during this pandemic. It is my great pleasure to bring and invite back Professor Kekar and Dr. Joseph Caprini to the panel. Dr. Joseph Caprini, as you know, is the creator of the world famous Caprini risk score, one of the biggest and most developed efforts for stratifying patients, specifically in the surgical setting, for defining their likelihood of having thromboembolism. Joseph has dedicated over 50 years of his life to the now vision of our foundation. He's a founding member of our foundation also. And he is really who instilled in me this idea of preventing globally thrombosis. Thank you very much. And then please, I'll have you access the next section.
Thank you very much. I'm sorry for the delay, but now my phone is unmuted. This is an incredible day, in my view. This is a wonderful symposium, and I would like to take this opportunity to not only thank Professor Lord Kekar for taking time out of his busy schedule to join us, but also it's very, I don't know if you could say ironic or not ironic, but I met VJ Kakar, his father, in 1973 when he presented at Loyola. And there's a, I would like to say there's a 10-ton elephant in this room. And that 10-ton elephant is the power of the multi-center Kakar trial in 1975 that people criticized but was validated with 70 more trials by Collins in 1988, and then on with AJ Kakar and Sylvia Haas in a very powerful study in 23,000 surgical patients in 2005 that have provided the framework, and it's still there, for thrombosis prophylaxis in the surgical patient, and also illustrated, and one of these days maybe the authorities will acknowledge it, the length of prophylaxis required to produce an efficacious result was 7 to 10 days. And in the Haas study with Kakar, it was 5 to 20 days. So I would like to publicly acknowledge again the incredible power of the Kakar family in shaping us right up to today. And what they have laid the groundwork is like solid pillars in the ground to be built upon. And in the background, Fareed and his group was putting together 25 to 35 abstracts and publications a year for the last 40 years in conjunction with that. So here we have the giants. And I must say that it's a great honor to be in the presence of these giants. And I'd like to start off by asking AJ specifically about about AJ, how do you approach the problem of surgical patients and having to operate on surgical patients, and knowing sometimes that these patients might have COVID?
Well, I mean, that does represent a particular challenge. So, of course, in the emergency situation, one is obliged, as we always are in emergency situations in surgery, to intervene. And of course, there are a standard set of protocols and measures that are taken. But what is very interesting is the approach we're taking to elective surgery, because we heard in earlier sessions the very deep anxiety we have in health systems now about the impact of COVID-19, not only in terms of COVID-associated morbidity and mortality, but the fact that our health systems are not being accessed by patients in whom elective surgical intervention has a very profound impact on their clinical outcomes, and that we are starting to see now excess deaths from, for instance, in the acute medical setting, a failure to present in a timely fashion with acute coronary syndromes, a stroke, and so on. But in the surgical setting, particularly the cancer surgical setting, what we certainly see in the United Kingdom, and where there is a great fear now based upon modelling of the epidemiological impact, what we are very fearful of are the very large numbers of patients in whom there will be missed or delayed cancer diagnosis, where surgical intervention will have an important role in terms of affecting cure or palliating disease, and where this delay will be associated with substantial additional mortality. So we do have protocols for COVID testing and isolation prior to admission to hospital for elective surgical intervention. But I think one of our very, very big challenges is to organize health systems to allow us to deliver both COVID and non-COVID care simultaneously and without interruption. And that is going to, I think, be identified as one of the very great failings, certainly in our health system, of having delayed intervention, particularly surgical intervention, in very large numbers of patients, where the benefit is ultimately lost to them.
Well, thank you very much. And I think you've put your finger on something which is incredibly important, and that is that this strict isolation has imposed a policy of delayed treatments for, especially for cancer. And I think that that's something that needs to be very, very carefully looked at as we go forward. And we can't all just stay stay completely isolated. We have to be very vigilant about that. Now, in this panel, by the way, I've highlighted the KCAR family and Professor Farid, but we've had some other giants from around the world in this particular session. And let's start with Dr. Ramakati from South America and the tremendous amounts of work that he has done and the tremendous amount of protocols that he's got involved in. I swear I know he doesn't go to sleep. But Eduardo, it's a great pleasure to have you as a part of this. And I wanted to ask you now, we have the situation where we originally there were COVID patients coming into the hospital without anticoagulation, and then we determined that they should get prophylactic anticoagulation. And then as time went on, patients were still clotting more and more and more. And so the prophylaxis in some patients was doubled. And the reason even is a recommendation with an elevated BMI that be doubled. And if there's time at the end, I'd like to address that. But more importantly, as the D-dimer levels were going up 5 times normal, 10 times normal, and the patients were getting sicker and sicker and going on ventilators and having increasing oxygen requirements and desaturation, people were going to full dose anticoagulation. So I would like to ask you if you could frame for us what your approach is to the anticoagulation part of this story. Eduardo.
Well, Dr. Caprini, can you hear me well?
Yes, very well.
We're still in the middle of a crazy pandemic here. We saw so many cases in my country, and I work in a public hospital. We're seeing 3 arterial thrombosis a day here. So we acquired a lot of experience with that crazy situation. And as a matter of fact, as of now, we're keeping prophylactic doses the way we learned from the guidelines previous to the pandemic. Because we don't have data yet to do this double dose or different creative doses. And I can tell you, we saw some bleeding with that creative things here. We lost a pediatrician lady, 38 years old, with intracerebral hemorrhage. I have personally taken care of some compartmental syndromes in COVID patients because of doubling the dose of heparin. So we really prefer to stick to what we have as of now and wait for the results of the clinical trials we know are going on everywhere. We're doing our own trials. I know Dr. Kakar is leading some trials with heparin, and we don't have this data yet. So as of now, we are sticking to the science, meaning we're using injectables, regular dose, and if you have a suspicion of venous thromboembolism, then you switch to full dose. But as a prophylactic measure, we're not paying too much attention to D-dimers, and we are extending the prophylactic strategy if the patient has a score like the Improve or the Caprini or PADO score high for 45 days based on the Mariner trial. And we are exactly at this moment studying rivaroxaban on the Mariner style for the COVID patients in a trial we're leading here with a sufficient number of patients. So as of now, we're sticking to the science we have at your hands.
So thank you very much. I want to stay with Eduardo a minute. I'm going to get all of those questions back to you, AJ, because I think that you have a very important perspective on this as well. But I want to dissect this a little more carefully. We know that patients without COVID-19 that have comorbidities, congestive heart failure, pulmonary insufficiency, COPD, BMI of over 40, diabetes requiring insulin, those types of patients, if we give them standard prophylaxis in the hospital without COVID, they break through frequently. So when you add a whole level of complexity to that with the COVID-19, Eduardo, are there any patients that, now I realize giving everybody full dose anticoagulation, that's a totally different topic, but do you consider any of those factors and giving a double dose of prophylaxis to those patients with serious comorbidities, including elderly patients?
Absolutely not, Dr. Caprini. The best thing we can do to our patients are putting them on clinical trials. So if we don't know what to do, we're putting them on trials. So double the dose, we don't have data. And I'm using the majority of my patients to put in the fair number of trials we're having here. We, as of now, doing three important trials from my view. One, extended prophylaxis for high-risk patients with COVID, full anticoagulation versus standard for severe patients on the ICU. And on the full anticoagulation strategy, we're testing those two strategies. One is full heparinization, the other rivaroxaban 20 milligrams, the atrial fibrillation dose. And we're also testing the hypothesis of giving anticoagulants at home for the sick patients with fever and high D-dimers to take a look at reduction in mortality and need for hospitalization. So as of now, we're doing, at least on the services I'm responsible, nothing creative in doubling the dose.
So now, Professor Kakar, would you please address these same questions, both who you use full dose in and when do you use full dose, other than, of course, established venous thromboembolism, and then the question of double dose.
Well, look, I completely agree with Eduardo. There are very challenging questions in terms of how we should best use anticoagulation. I was quite struck by the retrospective series published by colleagues from Mount Sinai Hospital in New York, looking at some 4,000 of their COVID patients and looking at the clinical outcomes and mortality rates associated with both therapeutic anticoagulation with a heparin and prophylactic anticoagulation. And what you see is that in both of those strategies, we know little about the nature of the patients and their underlying risk for poor outcome from thrombosis. But in both strategies, there was an important reduction in mortality and improved clinical outcome, admittedly retrospectively in non-randomized series. And Eduardo's explained the approach that many are taking. I think there are three big questions, as he has said. The first question, if we start at the far end, is for those patients who have survived their hospital stay. What should be our anticoagulant strategy in the post-discharge period? And there, I think it's reasonable, and there are studies that we've heard that are evaluating direct oral anticoagulants in that extended out of hospital phase to look at clinical outcomes. And there have certainly been in the series a very clear important number of patients who survive their ITU stay and die suddenly at home. And the presumption is in some of these patients, certainly probably an important number, this could be fatal pulmonary embolism. The second big question is what dose to use for patients in hospital. And I think in hospital we have to consider two principal settings: the setting in the intensive care unit and the setting in the general hospital environment. And in the general hospital environment, it seems intuitive until we have further data to use prophylactic doses of heparin. On ITU, I think there is a question about whether one should use higher doses for prophylaxis. And clearly, when a patient has established thrombosis, they should receive therapeutic doses. What we're doing in an international study in 10 countries is to randomize patients as soon as they're diagnosed in the community with risk factors for poor COVID outcome, to no anticoagulation, or to anticoagulation with low molecular weight heparin in a dose of enoxaparin 40 milligrams once daily, very early in the natural history of disease, to address the hypothesis that there must be something driving these patients to the emergency room and ultimately admission to hospital, and that's very frequently hypoxia. And that hypoxia may be driven by emerging intravascular intrapulmonary thrombosis, both pulmonary embolism and smaller vessel intravascular thrombosis, and that low molecular weight heparin might interfere with that series much earlier in the natural history of disease when activation of coagulation may be less severe. And of course, as Eduardo said, one of the countries we're running that study is Brazil, and we're very grateful for Brazilian colleagues' participation. So yes, there are many things that colleagues are doing, but you know, for all the benefit that anticoagulation provides, and there's the Active 4 program in the United States sponsored by the NIH, which is now going to explore in the community setting a randomization of apixaban to aspirin, and then in hospital parenteral anticoagulation, two separate protocols. Addressing this question appropriately with well-designed studies is clearly a very, very important consideration. As we'll hear later in this symposium, of course, we're most enthusiastic, all of us, about the arrival of vaccines. But I still think we have potentially a year or 18 months of managing important numbers of COVID patients, and getting anticoagulation right is clearly essential.
Thank you very much. Now we have other giants in the audience. The next, and I really got to know Dr. McBain through Alfonso when he came to join us. But Dr. McBain, of course, has made incredible contributions and the work in cancer-associated thrombosis for one. But because of the importance of this COVID pandemic, I'm taking the opportunity of the chair to ask you to address additionally all of these comments that and your reaction to the questions that we have posed so far.
Yeah. Thank you, Dr. Caprini and Professor Kakar. I appreciate the opportunity of participating in this important symposium. I don't have a lot more to add to what's already been stated. We too are very concerned about those patients requiring hospitalization, and I think the data would, as Professor Kakar has mentioned, would very well segregate or parse patients between ICU and floor settings. And so my review of the data suggests that the floor patients are not nearly as prothrombotic as the ICU individuals. And so we've developed our own in-house guidance, very similar to what's been suggested on the call today. And so what we do for patients who are on the floor is we give them guideline directed prophylactic therapy. For the patient who is hospitalized in the intensive care unit, we recommend a admission duplex ultrasound, noting that many patients who are in the intensive care unit may have a venous thrombotic event without clinical symptoms for a number of reasons. And then depending on their D-dimer levels, we would either give them aggressive standard dose of prophylaxis, or if their D-dimers are high, we would recommend augmenting the delivery of prophylaxis and include monitoring levels of low molecular weight heparin to make sure that we're getting the prophylactic dose correctly. And for those patients who then leave the hospital from an ICU setting, ultimately we recommend using risk scoring tools to determine who should receive ambulatory outpatient DVT prophylaxis post-hospital dismissal, very much like what has been stated on the call today. Fortunately, we are not hit with the absolute tsunami of COVID-19 that colleagues on the East Coast and the West Coast have seen, though maybe our tsunami is coming. But thankfully, it hasn't been overwhelming here in the southeast Minnesota area at this point.
Thank you very much. Now, Dr. Darkey, you've given us a wonderful lecture, and I wish we had time to explore all of that, but I would like to again ask you to give your comments on what we have discussed so far regarding COVID-19.
Thank you, Dr. Caprini, and I want to thank Dr. Kapoor and the PACO Foundation on the excellent symposium. I think basically everything that Professor Kakar, Dr. McBain, Dr. Ramakati have said is sort of our practice at our institution. You know, we in the ICU tend to have a higher thrombosis burden, and if appropriate D-dimer levels are at a level, we tend to intensify the anticoagulation. So I don't have much additional information to add. I do agree that you know, it's important to stick with the data and the science and not veer off too much from what we know.
Thank you very much. I have a question here that's come in from YouTube chat. I see tons of COVID patients who are home recovering nicely and never end up in the ED or hospital. Should I be checking the D-dimer and fibrinogen in these outpatients who seem to be doing just fine? Who would like to address that?
Well, I can help you with that, Dr. Caprini. D-dimer is kind of confusing too, you know. We're seeing so many D-dimers increase in these patients. They're doing so well. What we learned from the Chinese is that incredibly high levels of D-dimers, they correlate with mortality. But if the patient is doing okay, so why are you pursuing D-dimers? You know, so use it carefully. I don't see that much of use for D-dimers at this point.
I agree with that, Eduardo, completely. I think that one has to be very careful about using these biomarkers unless we have really understood their relationship to the natural history of disease. We may, otherwise intervene inappropriately in patients and put them at high risk of adverse outcome.
Exactly.
One of the comments from earlier this morning, I think, was really important. And this is a comment that our neurointensive care physicians have constantly asked and pleaded, and that is not to over-anticoagulate patients. If we are too aggressive and we tip the bar too closely to the bleeding side, we're going to see catastrophic bleeding outcomes, which combined with severe COVID are going to make for a mortality surge. And so, as we've all heard on in this morning's conversations, everyone, I think, is pleading for science and not deviating from all the wonderful work that we've already read, published, digested. I mean, we've got decades of good clinical judgment behind us, and we need to not throw that away just because of a deviation here.
You're quite right.
I'd like to add to that. I couldn't agree more with not taking all of that old literature and making sure that we apply it to the future. So, Dr. McBain, let me just stay with you and ask you, how would you implement a cancer-associated thrombosis prevention program? Is the DOAC data sufficient to consider at the institutional level?
Yeah, that's a really great question, and with the sentiment of the question is around prevention. So presumably we're talking about primary prevention for patients who have not had an event. So I love how Cleveland Clinic does their strategy for patients who come in with a new diagnosis of cancer. They start with a risk assessment tool using the Corona, and if they have a high Corona score, even if they don't have symptoms, they'll get a duplex ultrasound. And then as the oncologist is having these initial discussions regarding the implications of the tumor and all the associated treatment, I think that they need to be reminded that there is this thrombotic complication and that needs to be part of the discussion. We participated in the Cassini trial, and I found it to be very difficult to have the thrombotic discussion for a patient with a newly diagnosed pancreatic cancer, for example. But I think if we make it part of our system, part of our strategy, part of our ongoing discussion with our patients, this too needs to be part of the management strategy for cancer patients. So the DOAC data, in my opinion, is strong, and it's much more palatable than maybe a daily parenteral therapy. So,
thank you. So, Dr. Darkey, a question comes in: have you adopted the early discharge of PE on the Hestia, anchored on the Hestia scores, and should this be the standard of care?
So, Dr. Caprini, as you know, the recent ESC conference demonstrated the home PE trial, and we've had data before that from Merck and what have you. And I think there's an important opportunity here to focus on these low-risk patients that can be discharged, and it's not an insignificant number. We know it can be up to 30%, and particularly in the COVID era, getting these patients home, reducing hospital utilization. At our institution, we were sort of drawn by this data and have started to implement this program. It's important to have the correct infrastructure and follow-up with our group. It's a PE team having specialists from pharmacy, emergency room, and making sure they get followed up in the clinic. So I think to answer your question, it's an important opportunity, and I think it should become the standard of care in the years to come.
Thank you very much. Now here's one as we get ready to close. How do you unify PE nomenclature, where massive is often used to define clot burden rather than clinical presentation?
Another great question, Dr. Caprini. So true that massive clot sometimes refers to the anatomy, but the definition itself is hypotension greater than 15 minutes. But I do agree the nomenclature itself is inadequate, particularly as it relates to the submassive cohort. This is a largely heterogeneous population, and I think that as the field moves on, we've learned that using RV-LV ratios and just simple biomarkers won't be enough, and we have to expand it to physiologic parameters such as RV stroke volume and novel biomarkers that I touched on in my conference. So I think as that data develops, our risk scores will be better, and we can sort of refine the nomenclature to be more granular.
Thank you very much. Well, I must say it's been a great honor for me to be in the midst of all of these world experts. And I'd like to thank you all for beautiful presentations, for excellent questions, and especially for the Lord to take the time out from what's going on now, I'm sure, in Parliament and so forth. And I'll turn it over back to Dr. Tafur.
Thank you.
Thank you. Thank you, Joseph. This was a very beautiful lecture. As you know, we read and breathe thrombosis 24/7, and still this felt so fresh. I would like to transition to the next section, and thank you very much, all my friends here in this screen. It's a beautiful screen. I should have taken a picture. I would like to introduce Professor Rosana. He joins us as a infectious diseases expert, which is very apropos of the current scenario that we're living. He is very well funded with over 10 million extramural funding in NIH grants, Bill and Melinda Gates Foundation, CDC, and has a passion for molecular understanding of infectious diseases. Dr. Rosala is trained at Yale, and then he was a fellow at the Howard Hughes Molecular Medical Institute. It is really a pleasure to have you co-chair the next session, in which we're going to hear much more about what is new and what is necessary as far as creating a vaccine for this disease. Professor Rosala, please. We can introduce Professor Liviano as well to the screen so that we can get this organized.
Dr. Rosala, please be connected your audio.
Right, I think we can hear you. Well, Professor Rosala actually logs on it. Let me take the opportunity to welcome Professor Liviano, who is our panelist and going to give us the urgency assessment for what is happening with vaccines. As I think the sharing screen has been activated, so you can start presenting. So my privilege goes to you. Thank you for joining us today for the latest update on what is yet to be known about this vaccination process. Dr. Liviano is a physician from Colombia originally. He has a passion for epidemiological training, and then he comes with precision medicinal training in the CDC. So he is Ravi, are you on? So he joins us today with expertise also in the pharmaceutical industry as current vice president in the clinical safety benefit risk management for AbbVie. And please let us understand a bit more what is going on with the vaccination process and what is yet to come. I think your volume is needs to be turned on, Professor Levian.
Doctor, please turn on your audio. Doctor, please reload. Relog on.
Does he need to log on and off momentarily? Did that work? Professor Levian, can you hear us?
Doctor, please select the audio of your computer. Now you can select the call sound. No, please select the audio computer.
Thank you to the attendees. I'll request just a few minutes while we clean up the problem.
Hello, can you hear me now?
Perfect. Thank you very much. Welcome back.
Dr. Tafur, can you hear me?
Yes, we can hear you.
Thank you very much. We can see your screen, so I think we're ready to roll. Thank you much.
Okay, thank you. And sorry to everybody for the delay. Thank you for the invitation to the committee of the symposium. I will provide a brief update of the current situation with the vaccines developed for SARS-CoV-2 or COVID-19. These are my personal views. I base all that on my experience. I have worked several years at the CDC, WHO, and several pharmaceutical companies on vaccines, but what I present here is my personal views and a research of many papers that are out there. I will start by talking about the coronavirus, the vaccine development, the new paradigm to develop vaccines, how an ideal vaccine should look like, and the technology that we have used to develop this vaccine. We are going to discuss a little bit about the vaccine types, the safety and efficacy of some of the vaccines on whatever is available in PubMed, the implementation of the vaccination campaign once this is available, and then some other discussion topics. This is the coronavirus. It's one of the largest coronavirus from this family. It's about 30 kb, single-stranded positive. It's encased by a helical nucleocapsid. It has an outer envelope. Has an outer envelope, and basically we are targeting that S protein that you can see there. What we have seen with the previous vaccines developed for animals, coronavirus in animals, is that the immunity is not that good for those vaccines and is not long lasting. There is also a little bit of a concern that the vaccines can induce kind of a more severe disease with eosinophilia and some immune pathology that also results in poor protection. There's that concerns from animal models. Vaccines are really safe in reality. The vaccines, usually the most common adverse event is, let me remove something I have here. I don't like to see the middle of the presentation. Good. The most of vaccines have injection site reactions, and actually it's not uncommon to see with vaccines that systemic symptoms are kind of common as well, kind of look like a little bit fever or flu and self-limited. Allergic reactions with vaccines are very uncommon. That's something I have to say. It's 1 in 100,000, 1 in a million. The live vaccines may develop a mild infection. There's sometimes, very rarely, seen some neurological adverse events related to vaccines. Vaccine trials in general are placebo-controlled and blinded. The development of a vaccine usually takes between 10 to 15 years. They test several doses. That's why early approval of a vaccine may be risky. And nowadays we do trials with over 60,000 patients, 70,000 patients. This is just to monitor for safety. And we approve only after all the regulatory requirements are met and after phase 3. Let's talk a little bit about the new paradigm for vaccine development. In the traditional paradigm, we go from one phase to the other, phase 1 to A3. Phase 1 testing this efficacy. 2A, we start efficacy also as well. Phase 3, we test for safety. And we start manufacturing in large scales at the end of phase 3 when we are close to approval. We don't start manufacturing before. What is happening now is that once we have developed the candidate vaccine and we are doing the first in humans trials, companies are at risk already manufacturing millions of doses. And that's why it's so different. At this moment, I believe many of the companies that are the large companies that are involved in the development of the vaccine are already manufacturing hundreds of millions of doses. Then it's at a huge risk because they don't know if the vaccine will have enough safety and efficacy. That's why it's different right now. What will be the ideal characteristics of a COVID vaccine? It has to have an excellent safety profile in different populations, including children, older adults, pregnant women, immunocompromised individuals. Must not have contraindications or has minimal adverse events that are mild and transient. It has to be suitable to be applied to all the ages and provide, hopefully, some immunity with one dose, and that immunity comes within 2 weeks after vaccination. WHO has established that the vaccine should have at least 70% efficacy, another is immunopathology, and induced protection healthcare workers who may face high titer virus exposures. Hopefully this new vaccine will provide long-lasting protection, although there may be boosters necessary and maybe 1 or more doses. An important feature of this new vaccine that is stable at room temperature to avoid cold chain and transportation issues, and this is because we are going to vaccinate. This is one of the highest enterprises in humanity, vaccinate billions of people. Then hopefully the vaccine will be stable to sustain these large vaccination campaigns that will be coming, and that we can apply it with other vaccines. That will be the ideal characteristics of a vaccine developed for COVID. But today, we have used the technology to do a lot of things. As you probably are aware, the SARS-CoV-2 sequence was completed within 2 weeks and was made public. And we have been tracking for mutations. So far, we have not seen large mutations. There is also the synthetic generation of genetic material for some of the vaccines that's very quick. And artificial intelligence has helped us to sort and analyze approaches for any human team to achieve. That means if they see an error, they can just avoid that error and start with a neutral. Then technology has leveraged a lot of what we have today. But this is developing vaccines at pandemic speed. Let's remember, this pandemic started this year. And let's remember, this vaccine, the vaccine to be produced, should protect the global population from COVID-19. Then companies will have to work together, cooperate, because that's an absolutely important. It's like going to the moon. This is developing the vaccine for COVID is as serious as that. We should use different platforms of vaccination, and accelerate the pathways for approval. I know usually an approval of a vaccine takes between, let's say, 6 months to 9 months, sometimes a year. Here we are asking the regulators to look at all the information, all the necessary and statistical analysis, probably within a few months, 3 to 6 months. That's very quick for a vaccine that will be used globally. Also, we have to guarantee the supply chain, manufacturing, and distribution considerations. There's over 150 vaccines being developed. Of those, about 30 are in phase 1, 15 in phase 2. Phase 3 in large-scale trials have started, and at least 11 vaccines are there. Believe it or not, there are 6 vaccines that have been approved for limited use outside of the US, Europe, in other parts of the world. But at this moment, full approval has not been received by any vaccine. Again, back to the diagram of the SARS-CoV-2 variant. As I mentioned to you, these are the 4 proteins we are targeting: spike protein, nucleic acid protein, envelope protein, and the membrane protein. And these are the different types of vaccines, and we will talk a little bit about those. We will be talking about the live weakened version of the virus, the inactivated one, the subunit, the vector base, and the nucleic acid containing DNA or RNA. These are one of the methodologies that's probably doing most of the clinical trials, genetic vaccines. That's basically to deliver one or more of the coronavirus own genes into the cell to provoke an immune response. Why the companies and investigators have decided that this one, and they invested a lot of resources into this, because it's rapid and inexpensive, it's kind of easy to produce, it's completely synthetic, and it's cell-free. That means there's no need for biosafety labs. And that's very important, because if we are going to make 3 billion doses of a vaccine, that should be able to be done in different parts of the world. It's good that we don't need these very expensive biosafety labs. Has been derived from veterinary infectious disease uses. That means we have some efficacy and safety from those. But one of the complications that it might require some difficult delivery systems, and they are very fragile. That means they require an interrupted cold chain. As I was hearing from one physician that is doing a clinical trial, they request minus 113 Fahrenheit. That is it's a very low temperature. Very few refrigerators have that kind of temperature to keep the vaccine. We will be talking about the Moderna and the Pfizer vaccines, and the studies are ongoing with these 2. The second one that is most being used for this vaccine race is what we call the viral vector vaccines. Are vaccines that contain viruses engineered to carry coronavirus genes. Some viral vector vaccines enter the cells and cause them to make the viral proteins. I have some experience with this. I work in the Ebola vaccine that was made in the vesicular stomatitis virus. It's an attenuated virus, basically some innocuous for humans. And what they do is they build the genetic material in that vaccine, and that vaccine basically is given to the patient, and the patient will develop immunity toward that part of the genetic part of the vaccine. Again, there's experience from Ebola vaccine. There's the only one that has been approved with this platform. There's a potential for pre-existing immunity in recipients. Believe it or not, for the MERS, when we developed MERS-CoV vaccine, they were mild adverse events, but there was a limited humoral response. And there are 2, as I said at the beginning, there are 2 companies that already have approved some of these vaccines. The CanSino company in China was the first one to have a vaccine for COVID-19. I hear the military is being vaccinated in a phase 3 trial of about 500,000 patients, and that's in China. The other one is in Russia that was approved a few months ago. Then they removed the approval, and now they call it a conditional registration certificate. On October 17, the phase 3 trial was launched in India, United Arab Emirates, and Venezuela. I will talk a little bit less about the other kinds of vaccines that are being developed. The protein-based vaccines contain some of the proteins of the coronavirus, but no genetic material. They are focused on the S protein, as I mentioned at the beginning, is part of the capsid, part of the outside core of the vaccine of the virus. Is combined with adjuvants to enhance potency. That means already you can suspect they have a lot of adverse events. It's difficult to scale large production of the antigen with this one because you have to develop a lot of nanoparticles, and to scale it to billions of doses is difficult. The most common that you hear before is the inactivated, attenuated, as you remember, MMR, measles, mumps, rubella, varicella. Inactivated by chemicals or radiation, easy to prepare, low cost, quick to develop. They are adjuvated with alum. They have a high safety and variable efficacy. There is some concerns about what they call antibody-dependent enhancement when the virus become more potent in organisms previously treated with inactivated vaccines. They suspect that. There's some vaccines being developed here, not the majority. There's also the attenuated vaccines that are expensive and difficult to produce and may elicit long-term immune response. That's why we have long-term immunity to some of the vaccinations that were given when we were young. There's also some trials with BCG and MMR that have been done in different parts of the world. This is because the MMR antibody somehow is similar to the glycoprotein spikes. That's what they are saying, that maybe in patients very immunocompromised, these vaccines may help to boost the immunity of the patients. These are the most probable candidates to be approved. The Moderna vaccine with the National Institute of Health, they are testing several doses. It will be a 2-dose vaccine series recommended. The systemic adverse after the second dose are more common, but they so far have been mild. And it appears that it develops an immunogenic and robust response. I will bet this will be probably approved within the next 6 months. The other one is the biotech Pfizer that is similar to the previous one. It's a elicit similar dose-dependent neutralizing to comparable to the wild infection. It's mild. It can have mild to moderate systemic reactions and is dose-dependent. The major challenge, as I said, requires deep refrigeration. The company Pfizer has been requested to manufacture over 1 billion doses for the next 2 years. The other 2 vaccines that are most probably also to make it are the AstraZeneca University of Oxford that induce, it's a viral vector vaccine that induces humoral and cellular immune responses. With phase 2, they detected the antibodies that were detected in 91% of patients. Let's see what we see in phase 3. As probably you hear, the trials for this vaccine was stopped because of adverse events. They resumed back in Europe, but not yet in the US. The last one I will discuss is the Janssen Beth Israel Deacon's Medical Center, Boston. This has a vaccine that has provided protection in monkeys. It uses adenovirus as the viral vector. It produces humoral and cellular immunity. It requires 1 dose, and already the phase 3 studies have been started. The US government and Europe have requested hundreds of millions of this vaccine. As I said, on October 12, the trial was paused because of an adverse event that was unexpected. What is Operation Warp Speed? Basically, this is a US government operation to produce and deliver 300 million doses of safe and effective vaccine by January. HHS, CDC, NIH, BARD, and the Department of Defense are working on this. There is an accelerated development while maintaining standards for safety and efficacy. This is an important one. This is a draft from the National Institute of Health, National Academies of Science, Engineering, and Medicine, how we are going to distribute these vaccines. It will not all at once, obviously, because we cannot have the quantities. The phase 1 will be for about 5 to 10% of the population, will be the high-risk healthcare workers and first responders. The phase 1B will be basically for those people with severe high-risk underlying conditions. From there, the phase 2 will be about 35% of the population, the teachers and other people who is exposed all the time to the public. The phase 3 is about the other 40%, the majority of children and young adults that exist in the US. The phase 4 for everybody else. These are discussion topics I would like to have with you guys. When is going to be available this vaccine? Will this vaccine mutate, the virus mutate and the vaccine may not be efficacious? The efficacy of the vaccine. A question about if we are compromising safety because of the speed that we are developing the vaccines. More than one will be approved. Which one will be the one we'll use? The durability of the vaccine-induced protection. Do we need a booster? Do we need to pre-screen the patients? SARS-CoV will not be the last one, coronavirus. There are about 45 families of coronavirus out there, and we have to be prepared for the next pandemic. And we have to correlate protection and immunity to be developed from natural infection of wild virus. In conclusion, after 42 million cases of this pandemic and about 8.3 million in the US and over 1 million deaths globally, probably more than that, and over 200,000 in the US, is something that we should have done years ago. When I was working at the CDC 20 years ago, we were preparing for a pandemic for coronavirus. 7 years ago, there were publications in very serious journals about how this will be coming eventually, but I don't think we ever thought to allocate enough resources to make it happen. What is going to happen is that in the fall and winter of this year, the pandemic will again go back to very high numbers, as we have seen in the US. Yesterday alone, 80,000 new coronavirus infections. Then we need to do a lot on public health, but we cannot compromise safety and efficacy of a vaccine to be developed because of this accelerated program. We need vaccine advocacy. We need you, physicians, to help us vaccinate. We cannot spend the next 10 years to achieve 50% coverage. We need to achieve a very high coverage within the next 2-3 years. Eventually, we are going to control SARS-CoV-19, but with a variety of public health interventions that include from masks to social distance, vaccines, and many others. Thank you. You want to research more about the vaccines being developed? I put all the latest information there. Thank you very much.
Thank you, Professor Viviano. Ravi, I don't know whether your voice is on right now or not. If so, please go ahead. Professor Farid, welcome. I understand that you have a strong interest on pharmacovigilance as well, and then that is one of the questions that has arrived from the audience. So, as with the combination and complexity of two problems. So one, the fact that we have multiple vaccines racing to the end. And then with the complexity that is a worldwide problem, which logistical problems, which you touched base already partially in your talk, which logistical problems you anticipate for the reinvention of pharmacovigilance during the vaccine launching?
Is that a question, Dr. Tafur?
Yes. So basically, a brief commentary on from a question from the audience about.
Dr. Tafur, enable your audio.
Thank you. So yes, I was asking about the integration of pharmacovigilance problems that the occurrence of multiple vaccines arising to the end at the same time will actually arise.
Critical question, Dr. Tafur. The success of the vaccination program depends that we don't spread rumors that are false about the vaccine that is going to be approved. Very good pharmacovigilance, as we call it, proactive pharmacovigilance, targeted pharmacovigilance, will help us to identify this problem and correct them. We don't want rumors, as it has happened before with vaccination campaigns before, in which people start to be fearful of vaccination. This is the moment in which we have to come together and really research and do every best we can to report adverse events in the best way possible. We cannot just say the vaccine has killed somebody, because that will create panic. And let me tell you, the media will probably benefit from that. This is a serious situation which we have to do active and passive surveillance to make sure that the vaccine is safe, that we continue to monitor the vaccine, the post-marketing area, that means when it's being used in the population, and also to prevent rumors that may stop the vaccination campaigns in some countries.
Thank you very much indeed. Misinformation has been a problem throughout everything in this pandemic as far as thrombosis management foreseeably about vaccine management. A question that arises also in this chat box is what to consider as far as duration of the protection, especially knowing that post-COVID infection also, the number of months that we actually have antibodies is relatively short. So what will that actually entail as far as we keep maintaining immunity, and what's the duration anticipated, if you have any data on that?
I think one of the difficulties of approving the vaccine by the FDA, the EMA, and every other regulatory agency is to see good efficacy. Efficacy with perhaps 1 dose or 2 doses. That's what I was saying. In approving this vaccine, regulators should use everything at their hands and their disposal to make sure we approve the most efficacious vaccine that provide the longest, perhaps, immunity with the less required boosting. That's something we are going to see. But going back to the point, when we are going and working at the speed of light to approve this vaccine, it's dangerous that we approve a vaccine that may not be as efficient, or a vaccine that have a lot of adverse events.
Dr. Kapoor, I have a question.
Yes.
Professor Liviano, our president was treated with some very effective modalities. And in my discussions, you advised me that it was a cocktail of antibodies. And can you make some comments on therapeutic antibodies for the COVID-19 patients?
Yeah, and that's a very good question, Dr. Farid. Let's assume the vaccine may not be as effective. Let's assume there's difficulties to make billions of doses and make it available to the people. One thing that will help us is the additional therapies that are being developed, the immunomodulators and the monoclonal antibodies as the ones that we use for the president. As I understand, only few patients have been treated with those, around 250 patients only, or so. It's a very low number in any case. We are working on that in our company, Navi, on those. It will take several years to be developed, but perhaps for some patients, when the vaccine may be not efficacious or they don't get vaccinated, that will be a good treatment option. That's why to control this COVID pandemic, it will be a combination of all these factors, including vaccines, but also other medicines that will have to be developed to treat patients when they get the infection.
Alfonso, Ravi?
Yeah,
Perfect,
I think I was able to.
Thank you. We have your voice.
Finally,
Ravi,
yes,
yeah,
sir.
good. Yeah, I think that we should give you the podium now because you have the invited commentary. Thank you very much. Sorry we cannot see you, but I think we can hear you.
Yes. Well, no, thank you. And thank you, Dr. Liviano, for a wonderful talk. I actually followed all of it. I unfortunately had some glitch on my video not being accepted through the preferences, so I couldn't get in there. But, and I think the questions so far are, very appropriate in terms of efficacy, durability, and public acceptability for this. I want to, ask a question following on Dr. Farid's last comment about the use of passive immunization and the role of these antibodies, possibly you're mentioning in combination maybe with vaccines if we don't get the full efficacy. Such a thing, I know, the president received it and he's promising to make it free for everyone. Seems like a very expensive approach. And in terms of cost effectiveness of that approach of using passive immunization plus vaccine, any thoughts on how that could be managed, especially in parts of the world where this might be prohibitive?
Yeah, I think part of the solution will be make other things like remdesivir. Remdesivir has limited efficacy. They have not seen a change in mortality so far by the WHO, but I think it may, in some patients, may be beneficial. It might be available as well. the president also was treated with corticosteroids, and I believe that that perhaps helped a lot. And corticosteroids are kind of like very costly and very inexpensive and easy to acquire in every part of the world. Then I think what we need is to perfect what will be the ideal therapy. Vaccines will be only therapeutic, will not be for treatment. They will be, sorry, the vaccines will be only preventive, will not be therapeutic. The vaccines will be before the person gets infected. One of the problems that I see today is that a lot of people, they may develop again the infection. I suspect that perhaps they didn't have it in the first place, or that the immunity sometimes is not long. That means perhaps vaccine may fill the place of boost immunity even in those people who have suffered COVID-19.
Wonderful. Dr. Tafur, how are we doing on time? Do we have time for one or two more questions?
I think we should allow some flexibility given the interruption, and I don't see people logging off neither here nor in YouTube, so I think people are still attending. Perhaps we can consider one or two more.
Go ahead, Dr. Rusula. Go ahead and ask the question.
Okay, sorry, the connection was bad again. In terms of, and these are some of the questions that I know are commonly asked as far as efficacy and durability of vaccines and the potential for dealing with viral mutations. And, just if you could expand a little bit on the thought of the need to monitor for, evolution potentially of, viral resistance or viral mutation, and how that would inform ongoing vaccine development, in a model that may be akin to the influenza paradigm.
Yes, and actually I know that the CDC has a viral surveillance mechanism. They are monitoring the virus. As I said before, they are looking for large mutations. At this moment, they have not occurred in the samples they have acquired. Imagine, because it's an mRNA virus, there might be some small mutations that may be happening. But hopefully, the virus will be stable enough and the vaccines will be available, and we will be able to basically use them for this virus. I cannot predict if there will be a mutation. My suspect is might not happen. And if there is a mutation, there is also the possibility that it mutates to a less virulent kind of condition, a more mild kind of infection, as usually happens with some of these viruses. Then let's hope for that. If there is a mutation that is for one that in which the infection is not as bad, and that basically is more our own immunity can deal with it.
Wonderful.
Thank you.
Okay, Dr. Tafur, did anything else come in over there, question-wise?
No, those were the last, and the other topics were sort of addressed indirectly. So I think in the benefit of time and promise to all, we should start considering that closure. Professor Farid, I think you had some final comments along with Dr. Kakar. While that is prepared, please let me do some minor housekeeping issues. We were able to get over 300 attendees in combination of multiple audiences. I think this has been a nice session with tons of information. The CME to all registered attendees will be sent with instructions via email to the registered individuals. And finally, last but not least, I want to acknowledge the enormous help for Web Lab, for Guillermo Tafur, Claudia Boyle, and our sponsors in multi-levels, starting from Sigvaris, Jobs to Biotech Medi, followed with Juso, Recovery Force, and very nice auspices from Janssen and J&J for this meeting to have occurred. With that, I'll leave the podium to you, Professor Farid and Dr. Kakar, as to have the final comments on this very nice successful meeting. Thank you.
Thank you very much, Dr. Tafur. Before Professor Kakar gives his concluding remarks, it is my great pleasure to acknowledge both Drs. Darvasula and Dr. Levino's outstanding accomplishment and contribution to the international and global, national and global programs on vaccine, clinical research, development, and other educational activities in this area. Both have done remarkable work at our institution as professors there, and also in their capacity in international institutions and their own based organization. To recognize this, the PACO Foundation Board, as well as the International Union of Angiology, has recommended the awards for them. Can we show the awards there on the screen, Doctor?
We'll try to log on, Professor. I would like to continue though, as I'm having the.
Dr. Tafur, do you have the awards?
I'm logging them on, Professor. I think we should continue, and then I'll dig them up in a second.
So the awards for Dr. Levino's outstanding contributions in the pharmacovigilance program, his teaching and dedication for international programs, and most importantly, his interaction with the universities. This can be blown up a little bit or not possible. So this award is presented to him on behalf of the IUA and the PACO Foundation, and certainly it's an acknowledgement for his outstanding contributions in this area. The plaque and the award will be sent to him, and congratulations for that.
Thank you very much, Dr. Pray.
The second award is for Dr. Ravi Darvasula, who has, for the past 2.5 years, ever since he arrived at Loyola, developed outstanding educational, research, and collaborative programs. Also have global impact on immunology and vaccine development, unique vaccines, and has contributed significantly to our educational and research activities beside the clinical impact of his work in parasitology and so forth. So I just have great privilege in extending my congratulations on behalf of the IUA. And now I turn the chair for Professor Kekar to give the concluding remarks. Thank you very much.
Well, Professor Farid, thank you very much indeed, and thank you, Dr. Tafur, and all of the those involved in the organization of this outstanding meeting. We've had a really splendid program. We've been presented with data and with insights that are at the cutting edge of our understanding of cardiovascular problems and COVID-19, how they might be best managed, and the outstanding research questions that need to be addressed in the coming months. We've also had a most fascinating presentation on progress with the development of the COVID-19 vaccine and insights on the clinical challenges that remain in this important field. PACO Foundation is clearly an outstanding organization dedicated to education, and I strongly believe from what we've seen this afternoon, that it will make a tremendous contribution in the months to years to come in terms of achieving its objective of driving forward anticoagulation to improve patient outcomes. I'd like to thank all the speakers who've participated today as faculty, all of the delegates who have joined us on the digital platform, their insightful questions and contributions, and of course, Dr. Tafur and the organizing committee. Thank you very much indeed.
Lord Keker, thank you very much. Your sponsorship is a catalyst for a young institution. And with that, I would think the audience, we appreciate this would not have happened without you. Thank you very much.
Thank you. Thank you very much, Lord Keker.
Thank you. Bye-bye, everybody.
Bye. Bye-bye.